see in this topic the common symptoms in infancy. So let's start. Crying. Up to 20% report problems with crying in the first 3 months of life. Usually no cause is found. Crying peaks at 6 to 8 weeks old, approximately 3 hours per day, worse in the evenings, and subsides by 4 months. Cries of hunger and thirst are indistinguishable. The demand feeding versus routine feeding debate rages amongst parents, with each group convinced that they have the happier babies. Crying worsens, postnatal blues, and may be the last straw for a parent with few reserves. Aim to offer help before this stage. Don't make parents feel inadequate. Encourage parents to take it in turns to sleep. Explain normal crying and sleeping. Baby-centered approach to help parents help the baby deal with discomfort. Take parents' concerns seriously. Help parents recognize when their baby is tired and hungry, and to apply a consistent approach to care. Involve the health visitor, vocal, singing, vestibular, rocking. Going for a drive, or tactile stimulation, hugs, may help. Encourage help from friends, family. Simplify daily living. If not coping, admit to a parenting center or hospital. Don't over-medicalize. Colic. Paroxysmal crying with pulling up of the legs, for greater than 3 hours on is greater than or equal to 3 days per week. There is an association with feeding difficulties. Movement, carry cot on wheels, is often tried and may help. Let the baby finish the first breast first. Hind milk is easier to digest. If breastfeeding, a low allergen diet may help, as may probiotics. Reassure strongly. Reduce stress. Encourage grandparent involvement. Remember, a crying baby may be a sign of major relationship problems. Cow's milk protein allergy is a separate entity to colic, and is either IgE or non-IgE mediated. It causes colic symptoms, but also gastroesophageal reflux disease, blood, mucus in stools, and may result in faltering growth. In exclusively breastfed babies, ask the mother to completely exclude cow's milk protein from her diet. In formula-fed babies, change to a hypoallergenic extensively hydrolyzed or amino acid formula. Nappy rash, diaperdermatitis, 4 types, may coexist. The common, ammonia dermatitis, red desquamating rash, sparing skin folds, as opposed to seborrheic dermatitis, which doesn't, is due to moisture retention, not ammonia. It responds to frequent nappy changes. Cloth nappies retain more moisture than disposables, or nappy-free periods, careful drying and emollient creams. Best treatment, leave nappy off. Use barrier cream. For example, Sudocrem, zinc oxide cream. Candida, thrush is isolatable from tilde of all nappy rashes. Its hallmark is satellite spots beyond the main rash. Mycology. Treatment, as above, plus clotrimazole, plus or minus 1% hydrocortisone cream, no stronger, as Canesten HC. Avoid oral antifungals, hepatotoxic, and gentian violet, staining is disliked. Seborrheic dermatitis, a diffuse, red, shiny rash extends into skin folds, often occurs with other seborrheic areas. For example, occiput, cradle cap. An isolated, psoriasis-like scaly plaques, which can be hard to treat. Vomiting. Effortless regurgitation of milk is common during feeds. Posseting, vomiting between feeds is also common. Ask about carpets. Significant vomiting in a baby will have caused lots of damage to the parent's carpets. No damage. Unlikely to be pathological. Gastroesophageal reflux, gastritis. Overfeeding, 150 milliliters per kilogram per day is normal. Pyloric stenosis, projectile, at approximately 8 weeks old. Observing feeding is helpful in deciding if vomiting is projectile, for example over the end of the cot. Any infection, for example urina, adverse food reaction, infective gastroenteritis, rarer causes, pharyngeal pouch, poisoning, raised intracranial pressure, metabolic conditions, for example diabetic ketoacidosis, acute intermittent porphyria, almost any other illness, bilious, green, vomiting, get urgent help. Consider duodenal obstruction or volvulus. Chronic childhood illness and family support diseases such as asthma, CNS disease, and neoplasia may cause disintegration of even the most apparently secure families. Consequent strife and marital breakdown may be more severe and have far-reaching consequences. Remember that illness makes families poor, and movement down the social scale leads to unpredictable consequences in housing and unemployment. Families experiencing housing instability and food insecurity, without homelessness or hunger, are known to miss out on health care. Any holistic view of child health must put the family at the center of all attempts to foster child health and well-being. We see many families coping well with severe, prolonged illness in a child. But don't presume that because things are okay in clinic today, you can afford to neglect the fostering of family life. Given a certain amount of stress, almost all families will show psychopathology. In time, your job is to prevent this if possible. Counseling skills are frequently needed. Ensure the GP is fully informed, so that they are able to look after the parent's mental health. If you have any questions, let me know in the comments. If you like this video, please share and subscribe.